who have been unvaccinated to continue to still get vaccinated before booster doses are being introduced.
Okay.
But there's a great concern here in Malaysia, Monica. This thing is about whether the Pfizer vaccine is good against the Delta variant. And now they're talking about the Lambda variant now.
Yes, there was some data that came from Israel, right? It was like, what, 63% that they were showing efficacy against the Delta variant about immunized individuals. But I think we need to remember, what is the target we're looking for? I thought once upon a time we were happy with the 50% efficacy with the seasonal flu, right? And we still have good numbers. So better to get vaccinated no matter what the number is.
Yes.
Yeah.
Something is better than nothing.
Yes.
Totally agree.
So we are live. I just thought this was also an important discussion. So I let it continue. So good morning, everyone. Welcome from India, and good evening from a lot of viewers from all around the world. We are on 66th International Weekly Meeting on COVID in association with CMAAO, a session which was started by Dr. K.K. Agarwal 66 sessions before, a dream which he said that he wants to bring all medical associations and people related to the medical industry together to share a platform and information together. And here we are with the support of our CMAAO family, with the support of all the national medical associations. We have been very successful in sharing the information. Today we are on 10th of July, 2021, 9:30 a.m., which is an Indian Standard Time. And people from US have been joining in from the midnight. So thank you very much. We have a very important topic, especially important for Asian countries, where the population is very high. We don't get hospital beds. We don't get the proper medical care. So we have a very important topic, home isolation treatment for COVID-19. And to present this topic, we have Dr. Shashank Joshi. Dr. Shashank Joshi is a well-known endocrinologist and a physician in Mumbai working in Leelavati Hospital. He has been a past Dean of Indian College of Physicians and past President of Association of Physicians of India, apart from several other medical societies. He has published more than 800 research papers and is actively involved in COVID-19 evidence-based work. He is a very, very important active member of Maharashtra COVID-19 Task Force. And we have Dr. Shashank Joshi to present this topic. And before Dr. Shashank Joshi can present, I would like to invite our chair, Dr. Chong, with his update from Singapore, and all other country updates can happen after the presentation. Dr. Chong.
Thank you, Saurabh. Thank you very much. I'm looking forward to Dr. Joshi's presentation. Here in Singapore, things are cooling off. We had a mini lockdown, and we're coming out of it in the next week or so. This was because we had close to 1,000 cases of the Delta variant here in Singapore. And so we had to lock down to try to get it under control. But meanwhile, we have accelerated the vaccine program. I think we've got almost 60% of the population covered by now. And we aim to get close to 70-80% by year end, hopefully. Our National Day in August is coming up, and that's our target for us to get as many people as possible vaccinated. So the measures are working, and yesterday there was only just one case of COVID in our community. And I think that's the way we have to go. So we have to trace, we have to vaccinate, and we have to self-isolate, self-test. So self-testing kits are also available. And all our politicians and our leaders here are talking about the situation being endemic. They've said it many times, and I think this is the way to go. Thank you very much, and I'll turn over the session now to Dr. Joshi. Thank you.
Thank you, Dr. Chong, and thank you, Saurabh. This is a very important topic, particularly because we all know that COVID treatment at home is not an easy thing. It's like a double-edged sword. So how do you do COVID care at home? And what are the red flags and so on and so forth? So we all know very clearly that home care is all about isolation, hydration, and food. And we all know that home care is the fundamental tool in primary healthcare. And we know that, even before the COVID pandemic, it had a relevant role in controlling and monitoring people with infections. But we all know that there are situations where home care may not be perfect. For example, people who have terminal illnesses, people who have very advanced chronic diseases like dementia and COPD. And obviously, we need to be very mindful that we are today in a era of digital healthcare with telephone care and video calls. So what I am going to do is, talk a little bit on diagnosis and investigations, which we all know in COVID, monitoring the 7 vitals, because home care is all about monitoring. Dr. Chong just said about self-testing at home. Many countries, including UK and many other countries, are giving home testing kits now so that they can test early, isolate early, and take care of themselves early. And then, we have this big debate of treatment options. What works, what does not work? What are the red flags and transfer and triage? Because it's ultimately all about assessing a particular individual and then deciding when to transfer and when to triage. And then maybe a couple of take-home messages. So we all know, and this is from what Dr. Monica Vasudev last week very elegantly told us, that we understand the immune response to SARS-CoV-2 better. And we all know that if there is an adequate immune response, which is what the home care will center around, that if there's a good, robust immune response, which is there is a timely, innate, adaptive response for a very good type 1 interferon response, with activation of an efficient antiviral response cleared by macrophages, activation of Th1 and B cell responses making neutralizing antibodies, we are good. And recoveries of the day. While if there's an inadequate immune response, there's a delayed or limited type 1 endothelial cell death, epithelial or endothelial leakage, overactive T cells, NK cells, and activated macrophages, you get a cytokine storm. So that's what really happens. So it's all about recognizing that dysregulated immune response in COVID-19. We know 80% of COVID is self-limiting. So only that 20% which is severe, and it's that 1 to 2% which is fatal. And its whole idea is to recognize that who will progress and who will not progress. We know stage 1 is asymptomatic, there's innate immune activation, there is viral engagement of PAMs, and a low type 1 interferon response. We know stage 2 is non-severe and symptomatic, there is adaptive immune activation, generation of specific antibodies and T cell response, and release of DAMs. And it's ultimately the 3 C's we want to avoid: the complement, coagulopathy, cytokine release syndrome, which is a severe respiratory and inflammatory response. And that's really the key. But today we are in evidence-based medicines. And if you look at the NIH guidelines, they are probably the most rational and very cautious, and they tread on a very, very slim evidence, because COVID is predictably unpredictable, as I always say. And the rating of recommendations are A, strong, B, moderate, C, optional. And the rating of evidence as per NIH is 1 with one or more randomized trials without major limitations. 2A, other randomized trials or subgroup analysis of randomized trials. 2B is non-randomized trials, observational cohort studies. And 3 is expert opinion. So obviously, let us look at the various modalities. One thing is very clear cut, that as per the recommendations, we need to diagnose, we need to have a NAAT, which is a nucleic acid amplification test, whether it's from nasopharynx, nasal or oropharyngeal specimens. And we should not repeat it in an asymptomatic patient or a person within 90 days of a previous SARS-2 infection. So that's something which NIH recommends. So the level of evidence for testing acute COVID is A3. Non-repeat for an asymptomatic within 90 days is B3. And the panel also recommends there is no need for antibody testing as a sole basis for diagnosis, A3. And they recommend against the use of serological testing, whether the person is immune to SARS-CoV-2, A3. So that's where the diagnostic criteria stand. Now we know that today, as we talk on 10th of July 2021, COVID-19 has 3 subtypes. The first infection, or the COVID-19 naive infection, then COVID-19 breakthrough infection, which is a vaccine failure, and COVID-19 reinfections. Now, in population dense geographies like India, where I stay, Mumbai, we see all the 3 actually, because we have had now 2 waves, So we still see naive infection, predominantly generated by a Delta. We still see some amount of breakthrough infections, though albeit extremely rare. And we also are seeing reinfections. So we have been able to see, and we have seen, in the last couple of CMAAO meetings, and I'm thankful to Saurabh and Chong, that we have seen also small occasional cases of reinfection. Now, the main thing is that once you have diagnosed somebody at home, what are the potential biomarkers under investigations and the ones which we can do in a realistic setup in home care as well as hospital care. So we all know there are hematological biomarkers, there are biochemical biomarkers, coagulation biomarkers, inflammatory biomarkers, and some novel new biomarkers. So in that, probably the simplest is the complete blood count. And in the complete blood count, if you just look at two things very slowly and carefully, that is the red cell width and the neutrophil to lymphocyte ratio, we get reasonable certainty that there would be a progression. For example, if you use a simple yardstick that the RDW, the red cell width is more than 14.5, there's a very elegant JAMA study to document that there is a likelihood of progression. So it can red flag you one step up that if you have a complete blood count, your red cell width is high, you may deteriorate. If your NLR is high, you may deteriorate. If your platelet count is low, you may deteriorate. So that's one yardstick. Of course, a high neutrophil count, high WBC count, low lymphocyte count, low NK cell count can also be suggested. So those are the other markers. So whatever is put here out in the yellow are the ones which are commonly used. Whatever are the ones in the green are the ones where there is some evidence, and whatever is in the light yellow are the ones where there is emerging evidence. The biochemical pathways, we know the SGOT, SGPT are elevated, or LTSG, the bilirubin, the BUNs, the creat can be elevated. LDH is sometimes used, though we don't recommend it as a standard of care. Then, of course, we have the myoglobulins, CKM beat, the troponins, the CKs, and the low albumins. D-dimer has its own challenges, we all know that, but has been still used as a biomarker tool in the coagulation pathway. CRP, ferritin, PCT, IL-6 have been top of the pecking order, in which, if you see what I have picked up, is only the CBC and CRP. Because in a resource limited geography, if you have these two parameters, and if you see that the RDW is going up, NLR is going up, and the CRP is getting up, probably there is reasonable evidence to suggest that you need to move the patient from home to hospital. It may not be possible in every geography of planet Earth to look at LDH, D-dimer, IL-6, PCT, ferritin, and other tests. So that's something which we need to recognize the biomarkers. So the whole thing in home care is an ATM approach. We followed this in our Mumbai model very aggressively when we had a second wave. And each patient with COVID-19 needs assessment. An assessment at home, either digitally, virtually, and directly, either in person through a PPE kit, or can be done virtually through a video call. Ensure that you talk to the patient yourself and not to the relative, because that is crucial. Sometimes you can actually pick up on a virtual call that the patient is out of breath, patient is coughing constantly, patient looks toxic, and you can make a decision to transfer the patient ASAP. Because remember, home isolation comes with its own caveats, that we don't want the patient to deteriorate at home and then lose the patient because of a delayed transfer. So assessment is the key. Second is, of course, triage and transfer. And third is, of course, management. So it's very, very crucial that if you follow a simple ATM approach of assess, triage and transfer and management, we will be able to manage home care better and save every life which matters. So what assessment should be done? Well, we should monitor vitals. And in the vitals, look at temperature. If the temperature is more than 100 degrees Fahrenheit, simple paracetamol is good enough. Then if the pulse rate is high and if there is inappropriate tachycardia, we need to red flag. And if there is a persistent tachycardia, probably, and if it is coinciding with fever, it is okay. But if it is discordant, then you might take a decision about hospitalization. Look at simple respiratory rate. If it is more than 24, again, there's a red flag up there. Then look at blood pressure. If it is more than 140/90, there is an alert. Ensure that the blood pressure medications are taken. And as I said, the single most important, as we call it, the stethoscope for COVID-19 is the pulse oximeter. And it's the oxygen saturation. And it is a 6-minute walk test. And if there's a 3% drop on the baseline saturation, or if the baseline saturation is less than 93%, obviously you need to transfer the patient for better care. We also recognize the relevance of glucose today because you know that glucose is a vital sign to be assessed at home by simple self-monitoring of blood glucose. And if it is high, you need to alert it. And the seventh vital sign is that at home care, there has to be a digital or telephonic connectivity. Otherwise, it is better to quarantine that patient in a quarantine facility. So it's important to recognize that all these 7 parameters need to be monitored at home. Monitor the temperature, the pulse, the respiratory rate, the blood pressure, the oxygen saturation with and without a 6-minute walk test, blood glucose, and ensure that the person living with COVID is digitally and telephonically connected with a healthcare system for appropriate guidance on the phone. In absence of any of these, or if there is a red flag, it is better to err on the safer side. But we can manage most of this if we monitor them appropriately. Obviously, as I said, what do you do in assessment? If somebody has to assess for persistence of fever. If somebody is having persistent pyrexia over 5 days, persistent dry cough, breathlessness over 5 days, and persistent fatigue over 5 days, it may be appropriate to transfer the patient. Some people may experience loss of smell and taste, aches and pains, nasal congestion, runny nose, sore throat, and diarrhea. And these individuals may or may not need, a hospital care. Look at travel history. Look at whether the person is a healthcare worker or not, because the ability to monitor in a healthcare worker and a person is very, very different. Now, the most important thing at home care is to diagnose hypoxia or the occult hypoxia which we pick up. And also remember that occasionally COVID can present with some mimics. For example, acute cerebrovascular strokes, acute coronary artery syndrome, seizures, and even diabetic ketoacidosis. So we have seen that presentations also coming up. Now remember that in COVID times, in high-risk geographies, assume every patient to be positive until proven otherwise. We often use in home care as well as in emergency rooms the NEWS score, which is the National Early Warning Score. And we look at respiratory rate there, the saturations, the air and oxygen saturation, the systolic blood pressure, the pulse, the level of consciousness, and the temperature. And we look at the NEWS score aggregate, and based on 0 to 4, 5 to 6, and more than 7, we decide whether there is an urgent or emergency response, maybe an urgent ward-based response, or a simple response. Now, as I told you that diagnosing silent hypoxia is the key in home care. And we know the ease of use and the low-cost pulse oximetry. But it's important to recognize that there are pocket oximeters, smartphone-based systems, and their accuracy may not be appropriate. So we do not encourage the telephone-based oximeters. Ensure that you have a simple pulse oximeter at home and ensure that we measure it appropriately. Remember, there are situations where there could be a lot of errors in pulse oximetry, and they can account for rapid fluctuations because we know that the arterial oxygen pressure and tension falls with a steep proportion of the dissociation curves. So remember that if there are data acquisition problems, usually they are seen if the pulsatile blood flow is diminished and if there is severe hypoxemia or a dyshemoglobinemia or other issues. So it's important to recognize that we understand the pitfalls of pulse oximetry. We need to ensure that the type of devices and how they operate is very important. Remember, all pulse oximeters provide an indirect estimate of arterial oxygen saturation, which is the percentage of hemoglobin binding sites occupied by oxygen, which in turn is a function of the PaO2, the arterial oxygen pressure and tension, defined by the hemoglobin oxygen dissociation curves. And the principles by which these estimates are derived varies on type of the monitoring device. So remember that the pulse SpO2 refers to pulse oximetry measurements and is a value directly measured from arterial blood by co-oximetry as denoted as SaO2. So obviously these are the two general categories of tools of pulse oximetry. So when monitoring their saturation at homes, individuals should be at rest, breathing quietly without talking for several minutes before taking the measurements, and preferably be unmasked, because if they are isolated and they are unmasked, often the reading will be different from if they are masked. Measurement should be made indoors with the device seated securely on the middle or the ring finger rather than the earlobe or the toe. Nail polish must be removed from the finger on which measurements are made. And remember, cold extremities must be warmed prior to the measurement. Rather than accepting the first number which appears on the screen, individuals must be patient to observe the reading for at least 30 to 60 seconds to identify the most common measured value and accept only those values which are associated with a strong pulse signal. So if the pulse signal is not strong, and if you don't wait for a minute, you can lead up with the erroneous reading. And the value should be measured multiple times of the day to gauge accurate trends of arterial oxygen. Obviously, we know the 6-minute walk test has probably the best yield in terms of diagnosing occult hypoxemia and saves lives. So the whole idea from the ATM system is to triage the patient, whether the patient is in the red, the yellow, or the green signal. So obviously, when you triage the patient and when the patient comes to the ER, we have to find out whether the patient is unstable and if it's a COVID suspect and needs ICU or does not need ICU. Is the patient stable and needs isolation or wards, or patient has no COVID and needs some emergency surgery or medical case? So obviously in the triage, we have to look at alternative diagnosis if the patient is COVID negative and decide whether the patient needs to be at home or can be kept here. Now remember, the red flags are very, very crucial. And the red flags are if the news score is more than 5, a single news parameter is more than 3, if there's sudden onset breathlessness, or there's a positive 6-minute walk test, you need to keep the patient at the hospital and then measure the saturation and then decide whether the patient needs intubation, transfers to ICU or not. So remember that it's very, very crucial to decide about the transfer and triage decision based on the need for oxygen, need for ventilation on invasive, non-invasive ventilation, and ensure that we need to have appropriate hospitalization to save patient's life and reduce mortality. So obviously we all know this mild, moderate, and severe categorization based on saturation, respiratory rate, judicious use of labs and CT scans, which I'll allude to a little later, and then look at management. But the biggest challenge at home is outpatient management of acute COVID-19. And we all know that it's all about supportive care. It's all about isolating the patient. It's all about patients to be advised on connect with the healthcare provider and seek in-person evaluation if needed. So the level of evidence here for isolation, being connected with healthcare provider, and at least one inpatient evaluation is A3. Now, all patients must have their symptoms of COVID to be triaged, either via telehealth visits before receiving inpatient care. If the person has dyspnea, it should be referred for in-person evaluation by the healthcare provider and followed closely in the initial days of the onset of dyspnea and assessed for worsening of respiratory status. The level of evidence is A3. And obviously, management plan should be based on the vital signs, which I alluded to: physical examination, risk factors of progression to severe illness, and availability of healthcare resources. For example, access to healthcare facility may be tough. And if there is a provision to have the patient to be quarantined into a healthcare facility, which may not be a tertiary care facility, but oxygen facility, that also can be done. The level of evidence there is A3. So also another important thing to recognize is to understand COVID timetable. Acute COVID has a timetable of 14 to 21 days. Often what we see is a lot of asymptomatic patients get into hypoxia on day 7, day 8, day 9, day 10, day 11, day 12. So it's the 8 to 12 days which are very crucial. And if we miss them, they suddenly land up with breathlessness on day 10, day 12, and we have lost patients there. So we need to recognize that better. And we need to understand that COVID timetable is between 14 to 21 days. We have also seen delayed storms in 10% of our cases. And also remember, post-COVID care is around 100 days or 3 months. So it's all about timing, the right approach, the right time, the right meds. Don't use antimicrobials or antiparasitic agents empirically. Insist to speak the patients on phone if you are doing them at home. So remember that when you manage them outpatient, all patients with dyspnea or people who have desaturated at room air below 94% or who have symptoms suggesting high acuity like chest pain, tightness, dizziness, confusion, or other mental status changes, they must be referred for an in-person evaluation by a healthcare provider. So remember, these are clear-cut red flags. If somebody is dyspneic, somebody's saturation is low, somebody has chest pain, tightness, dizziness, confusion, or mental status changes, or simple persistence of pyrexia for 5 days, persistence of cough for 5 days, fatigue for 5 days, then look at that. Also remember that if the person is elderly or has comorbidities where the risk for progression is higher, then it's better to have an in-person evaluation. Ensure also that when you are taking all these decisions of triaging, look at ambulance transport and ensure that these transport facilities are available. So what are the specific treatments for outpatients with mild to moderate COVID which can be given at home? Well, the only treatment which has been evidence-based, which has been recommended by the NIH panel, now it's available in India and many other parts of the world also, is a combination of anti-SARS-CoV-2 monoclonal antibodies to treat mild to moderate COVID. And in that situation, there is, of course, in India, what we are available is casirivimab, 1200 milligram plus indivimab, 1200 milligrams. In India, we have the doses available as 600 plus 600. The level of evidence here is A2A. So it's not the best level of evidence, but it's still better than nothing. The very clear data now emerges that there is no role for use of chloroquine and hydroxychloroquine with or without azithromycin. A1 level of evidence. So now data on hydroxychloroquine, chloroquine is more or less simple, and I think that is out completely. There is really no role for dexamethasone or other systemic steroids in outpatients situation, except if there is another indication. So if there is a pulmonary indication, chronic pulmonary indication, that you can still use steroids. Otherwise, routine use of steroids in an outpatient setting, A3 level of evidence. There is clear data to show that there is no data to use these because they may cause actually harm. Also, the data clearly is there against antibacterial therapy, whether it's azithromycin or doxycycline, in absence of another indication. So now there are RCTs in these spaces. And then there are investigational therapies. So I have been deliberately silent on ivermectin here because ivermectin data is neutral. It is neither for nor against. And therefore, whether we should recommend ivermectin or favipiravir or molnupiravir, which are all undergoing investigations, are matter of subject and debate. So where will we use ivermectin? Where will we use favipiravir? Where will we use a molnupiravir? So remember that active viral replication is most in the first 2 to 3 days. So if at all you want to use a favipiravir, which we use sometimes in India, it works best if it is used in the first 48 hours to 72 hours. Usually we use a large bolus dose followed by a maintenance dose, and standard of care is not established in favipiravir in terms of mortality outcomes. It has data for a faster viral clearance. That's the data which is available, and a little early symptom relief. But nothing beyond that. It doesn't have data of the quality of remdesivir. The molnupiravir 800 milligram twice a day for 5 days is undergoing trials both in the US and in India now, and we will have data maybe in another some time down the line. Ivermectin 12 milligram twice a day for 5 days is an investigational therapy as of now. It is neither recommended as for or against. So all these three therapies, if you ask me, are in the experimental mode. They are not even in the EUA mode. They are not standard of care. But casirivimab and indivimab, 600 milligram of each, has been available now in India, but it's prohibitively expensive. So obviously, what are these monoclonal antibodies? We all know that active immunity, the seroconversion occurs 1 to 3 weeks after COVID infection. And passive immunity is administration of monoclonal antibodies or covalescent plasma. We know covalescent plasma has failed, at least in the late stages of the disease. Early stages, high titer covalescent plasma, whether it will work or not, we don't know. But the data has not been very supportive and has been pretty disappointing in that space. But monoclonal antibodies have been quite popular. We know these monoclonal antibodies, they target specific viral epitopes. They are mass produced. They are nothing but extracts of these covalescent plasma, and they do not rely on donors for supply, and we can have known quantities. So fundamentally, what these monoclonal antibodies do, they are spike proteins which facilitate host viral attachment at S1 and S2, and they bind to the RBD domain of the spike protein. So that is what the monoclonal antibodies do. And the one which is available in India now is the Regeneron antibody, which is the casirivimab and indivimab. These are all tongue twisters. And they have got US emergency use approval, and similar approval is available now in India and many other geographies of the world, including places like Singapore. So where do they use it? Well, in high-risk situations, if the BMI or obesity is there, CKD is there, diabetes is there, immunosuppressive disease, people receiving immunosuppressive treatment, and elderly. If they're above 55 years of age, people with cardiovascular disease, hypertension, COPD, and other chronic respiratory disease. And between 12 to 17 years of age, if they are obese, sickle cell disease, congenital acquired heart disorders, neurodevelopmental disorders, medical related technology dependence, asthma, reactive airways, chronic respiratory disease. So obviously these agents, if used in the first 72 hours, remember the data on monoclonal antibodies in the first 72 hours, if used appropriately, can be life-saving. So the challenges here are how to identify patients, proactive or reactive, what are the criteria. So here you can see this is a UTA COVID risk score. If the patient is male, you can give 1 point. For every decade, you can have a point scoring system. For example, if somebody is now 72, then the score is 4. But if somebody is 34, then the score is 2. Then the ethnicity matters. And if it is a non-white race or Hispanic race, then the score is 2. If there is a comorbidity like diabetes, the score is 2. If there's severe immunocompromised state, the score is 2. If there's obesity, the score is 2. If there is other comorbidities like hypertension, coronary artery disease, cardiac arrhythmia, congestive heart failure, CKD, chronic pulmonary disease, chronic liver disease, cerebrovascular disease, chronic neurological disease, shortness of breath, the score is 1. So obviously, you can actually triage and decide whether your patient fits the score. Timing, well, the data is published data on outcomes is all in the first 72 hours. You can use up to 7 days, but the latest data from recovery trials shows that you can use it even later. And that's very, very interesting. How to use the drug or infuse the drug, you can give it subcutaneously or the IV infection. You need to look at various other conditions which are there. And the main question people have is, will these monoclonal antibodies work against the new strains or the new Delta which has come in? All these strains which are there now. We have the Alpha, and we know that it is highly transmissible, but vaccine effectiveness is there, but it cannot be immunoinvasive. Then we have the Beta, we have the Gamma, we have the Epsilon, the Iota, and of course the Delta. And this is data. The CAS IMD is what is available in India, and the other antibodies are not routinely available. They're not very popular. And you can see that the CAS IMD, which is available, virtually is effective against all the strains. You can see here all the strains are listed here in their RBD mutations and probably is effective. This is the graphical data to show that these antibodies have some impact on the various new strains which are there. So summarizing on monoclonal antibodies, there is reasonable evidence to show that for people at home, they can come to an ER and get for ambulatory patients with high risk of subsequent complications. So we know that somebody is likely to deteriorate, obese patient, CKD patient, diabetic patient, likely to deteriorate. Okay, if you give them early and they are seronegative, they are likely to benefit from that. Well, for household contacts also, people have recommended them for post-exposure prophylaxis, but we don't use that in India. For seronegative patients in hospitalized for COVID, this is emerging data. So data is still early, but CAS IMD appears to be effective against variants of concern, including Delta. Cost is the only rate limiting step. So we have an option at home now, which has data with A1 or A3 level of evidence. Current level of evidence is A2. The next thing is the inhaled budesonide. This got in a lot of popularity, and there is a prospective randomized control trial which compared 2 puffs of 400 micrograms taken twice a day of inhaled budesonide. And it's a very simple thing which one can do. And they said that if you use early use of inhaled budesonide in SARS-CoV-2, you can reduce the need for urgent medical care and enhance recovery. We recommend it for persistent cough more than 5 days. And obviously, this is something which can be easily done at home care level. The third thing in home care is colchicine. And we all have seen the Colcorna trial. It was a phase 3 randomized double-blind adaptive placebo-controlled multi-center trial. We all know that this was a trial which was done in Brazil, Canada, Greece, South Africa, Spain, and US. And it was basically led by the Montreal Heart Institute. And here what was done was colchicine was given 0.5 milligram twice a day for 3 days, followed by 1 daily for 27 days. As physicians, we use sometimes for acute gout 6 tablets of colchicine or 0.5 and then followed by 2 tablets after 6 hours. So obviously, this is a very old anti-inflammatory agent. It's economical, and they looked at a placebo-controlled trial, and they are looking at whether this can be used as an anti-inflammatory agent because there is data to show that it is beneficial in gout, pericarditis, coronary artery disease. Can it be a simple agent which can be having an impact on COVID composite, COVID death and hospital admissions? So obviously, this trial is now completed. It's published also, and they ensured that the trial colchicine led to a lower rate of composite death or hospital admission than placebo. And given the absence of administered therapies to prevent COVID complications in community treated patients, the benefit of colchicine is safe and inexpensive and can be considered for those in use with risk of complications. So again, this is a cheap oral option, but as I said, that the data was not statistically significant on the clinical events, but on the composite of death and hospital admissions, probably colchicine may have a role. So colchicine is there. It's a little controversial, but probably is a cheap oral effective agent, which is why I'm discussing it here. As I said, the key is to pick up people who are at home, who will deteriorate. So if the viral load is very high, if they have severe immune dysfunction, if they have rapid deterioration on their chest parameters like desaturation, then maybe on day 5, sometimes we do a CT scan, biomarkers, and so on and so forth. So the idea is that we need to treat people at home, but pick up if they have constitutional symptoms like fever, dry cough, lymphopenia. They can be managed at home. They will recover. The key is that pick up people between 2A and 2B. And if they are going to be short of breath with hypoxia, with abnormal chest findings, some transaminitis, obviously they need to be hospitalized. So obviously, if there is a host inflammatory response in the pre-cytokine storm phase, that's the time to diagnose, detect, and then transfer and triage. So that's the crucial thing which we need to recognize. So obviously, COVID care is all about the right medication at the right time. And as I told you that you need to know when to use steroids, usually late, when to use low molecular heparins, usually late, when to use antivirals, mild to moderate, maybe orals like favipiravir and molnupiravir, which is undergoing trials, may have a role in mild to moderate or home disease, but the data has to be generated on mortality, but viral clearance may be better, symptom recovery may be better. Remdesivir, again, no mortality data with us. Moderate to severe COVID in the first 10 days may be effective. We know that the injectable remdesivir may improve clinical recovery and length of stay in the hospitals, but nothing beyond that. So obviously, those are all hospitalized situations, but it's all about ensuring that we protect ourselves, maintain communication, and transfer patients on time. So finally, at home, we can recognize and manage people at home with COVID. 80% of people can be managed by good home isolation, by good care, ensure that their hydration and nutrition is taken care of at well. They monitor not only their temperature, pulse, respiratory rate, blood pressure, glucose, but predominantly the pulse oximeter and oxygen saturation at least twice a day, and stay connected with the healthcare provider. We need to recognize red flags. If there's desaturation, any new score more than 3, if there is definitely someone who's completely fatigued, out of breath, or toxic, elderly, or comorbidities, at least call them into an ER and evaluate them. If in doubt, transfer. Ensure that these are isolated patients, so take care of their mental health, keep them cheerful and positive, but not reckless and mindless. The biggest challenge which we see in home care is asymptomatic people, because asymptomatic people could be spreaders and super spreaders, could be reckless, could be susceptible to happy hypoxia in the 2nd or 3rd week, and they need to recognize the timetable of COVID better. And home precautions also involve family members, and we need to ensure that the family members are screened, diagnosed, tested, and also self-isolated appropriately. Also remember that many of the home care patients still can need post-COVID care. It's not that home-based patients do not need it. We need to diagnose occult lung issues, cardiac issues, diabetes, neurological and mental issues, fatigue. So remember that post-COVID, these patients must be screened and evaluated, maybe at 2 to 3 weeks, and evaluated for various complications for a period of time. So we need to ensure that they eat appropriately and on time, eat the right food, they sleep adequately, and they also are cheerful. Hydration and ensuring optimal calories with adequate protein is the key. And that's something which we need to recognize that in home care has been very, very important. We also need to ensure that they don't get negativity on digital medicine, because nowadays with the advent of various universities like Google and WhatsApp, patients get cluttered and they get anxious, and that anxiety drives them to get symptoms which are often false alarms, and they occupy hospital beds. So we need to tell them that they need to digitally detox. They need to seek question and answers through counselors and healthcare providers who can allay their anxiety. things where people have anecdotally tried things like melatonin, which may have a role. They have tried maybe zinc, vitamin D, vitamin C. But remember, none of these micronutrients have any role. I didn't discuss them in my home care, and they need to sleep well and sleep on time. Obviously, when you stay home, you need to stay safe and stay clean. So it's very, very important that the standard disinfection protocols are followed, disposal protocols are followed. And we know that we need to be responsible. Though, we are staying and living with a disease which is predictably unpredictable, we need to save lives. But we can manage people at home. Remember, 80% of COVID can be managed at home, and it can save a lot of healthcare resources. But we also need to recognize that we need to detect and diagnose the red flags on time so that we can save every life. And we need to be responsible. So the onus is on the doctor and the patients, and we have to be in a connected system. At any point of time, either of them are not confident of handling this, then it is better to get them inpatient in a facility. I'm certain that I may not have been able to cover everything, but I'll be more than happy to answer any questions which may be there. Thank you for a patient hearing.
Thank you so much, Dr. Joshi. I think it was a wonderful presentation. And I would say if some data has to be present, India has a lot of COVID patients. One of the wonderful data you can present, and thank you so much. I see we have 38 audience, so which is a good number. Over to Dr. Chong. Dr. Chong, would you like to take it up? Okay, so let me introduce. Okay, so I forgot. Sorry, I was so deeply involved in the presentation, I forgot to introduce the people, I would say. We are a member association. Like there are a lot of people, members and presidents who join this meeting. We also have now audience coming up from various part of international group. So I would like to take an honor to introduce who are our regular attendees over here. So Dr. Chong, obviously from Singapore Medical Association, he's a chair for CMAAO. We have Dr. Ravi Naidu from Malaysian Medical Association. He's also the past president of past president from CMAAO. Dr. Professor Ashraf from Pakistan Medical Association. He's also the first vice president of CMAAO. Dr. Elvin from Hong Kong Medical Association. He's also the treasurer from CMAAO. Dr. Matanda Pillai from World Medical Council and Sri Lanka. Dr. Salma from Pakistan Medical Association. She's the president of Pakistan Medical Association. Dr. Angelica, president for South Africa Medical Association. Dr. Jamal Chaudhary, Bangladesh Medical Association. Dr. Akhtar Hussain from South Africa Medical Association. Dr. Mukti from Nepal Medical Association. Dr. Subramaniam from Malaysian Medical Association. Dr. Sajjad from Pakistan Medical Association. Dr. Deborah from Brazil Medical Association. Dr. Marie from Japan Medical Association. We have our speaker, Dr. Shashank Joshi from India. Dr. Hussain from Pakistan. Dr. Monica Vasudev from USA. Dr. Sanchita from IGCP Group. Dr. Meenakshi from Heart Care Foundation of India, and myself, Saurabh Agarwal. And I would also like to acknowledge the presence of all the audience from Singapore, Malaysia, and all other locations who have joined to attend this presentation. Dr. Russell from UNESCO, I have missed out his name. I just see him. Welcome, Dr. Russell. I hope you're fine. Okay, so Dr. Chong, over to you.
Thank you, Saurabh. And thank you, Dr. Joshi, for that very nice presentation. I always start with a couple of questions myself before I throw it open to the floor. And it's quite interesting that you talk about the Avigan, which I think is from Japan, Favipiravir. And you also talked about the colchicine, which I found very fascinating. And colchicine is such an old drug. I remember that it inhibits the spindles in the rapidly dividing cells, in white blood cells, and in the gut cells. That's why they have diarrhea. And I know there's also some trials that show that it seems to help in cardiovascular disease. Could you tell us a little bit more about colchicine? Found it very fascinating.
Sorry, I think I got muted. So
yeah, sorry. So I have unmute everyone. Because I think the presentation time I did mute everyone. Yeah.
So, Dr. Chong, colchicine is a very old drug. You are very right that it has been used in a lot of other areas. And the Colcorna trial found that in the community space, we don't have too much of anti-inflammatory agents. So they found it useful. They reduced the composite death and hospitalizations. And the dose they used was simple, 0.5 twice a day for 3 days and then 0.5 daily for 1 month. Of course, there are people who feel that this composite death may not be appropriate. So there's a lot of criticism on that. So that has been really looked into. But I think it's a very cheap and effective agent available with us. It should not give us any false sense of security. At the same time, we should continue monitoring our people. But it's something which we can use very easily and has been used. There are a lot of other anti-inflammatory drugs also in this space which can be used. Remember, COVID is all about inflammation. So it's an anti-inflammatory drug and it works. So Colcorna trial, as I said, they have published an RCT. So the whole idea is that in COVID science, we are always having new things coming up. For example, when COVID started, we never thought steroids will be standard of care and will have generate that quality of evidence. So, this was the latest piece of evidence in home care. It's an option we can explore. But in home care, it's all about supportive care. It's all about if the persistent pyrexia is there, just use simple paracetamol. If there's persistent cough, use an inhaled budesonide. If symptoms are persistent, you can use anti-inflammatory like colchicine. That's all I can say. And we have now a monoclonal antibody option also available. In the US, I'm told this has been used very effectively and they have been very successful. They have had their past precedent also using it. In India now also, in many cases, we have been able to use it. I wish it was available a little earlier to us. It has its own limitations because you know that if somebody is already vaccinated, then the likelihood of the response to the antibody is going to be weaker or lesser. So we don't prefer to use it in those situations, though we have also used it in some breakthroughs. But I think colchicine is an easily available, cheap option. I would still say it's in the research or investigational mode. I would not put there right up the pecking order, like a standard of care.
Yeah. But the interesting thing is that there's very little harm when you give colchicine, So yeah, so that's the
diarrhea. There is no real harm in
there's no real harm. So fascinating. Some of my Singaporean colleagues are very interested in ivermectin. I know you deliberately don't want to talk about it, but maybe you just say a few more words about it.
Yeah, I don't mind talking on ivermectin because one of the early data which we published also a long time back, when there was no favipiravir, no remdesivir, was on ivermectin.
Yes.
But the dose we used in home care was 12 milligram twice a day for 5 days. So, it's all about dosing. So you can have a per kilogram per milligram dosing. But the data generated on evidence-based RCTs on ivermectin is very scant or poor. So now there are two worlds, in the anecdotal world of ivermectin and in the evidence-based world of non-ivermectin. So for me, even today, it's an investigational drug, and it's a drug with a lot of excellent anecdotes. But because we live in an era of evidence-based medicine, it lacks the quality of evidence to be generated to be there on any guidance. As I said, it has some weak guidance in symptomatic mild space, but I think there are drugs which might have a better impact. So what do these new drugs, none of these new drugs, even favipiravir, which is a Japanese agent, has not really made the cut. They may be very useful for viral clearance, but we don't know whether they delay the response to moderate to severe disease. That's number one. Number two, we don't have outcome data to show that they reduce mortality.
Yeah.
If you do head-to-head trials with a placebo, molnupiravir is doing such a trial. Phase 2 trial data in a preprint format is out. And that data is very clear that if you give molnupiravir 800 milligram twice a day for 5 days, this is a US data. It's a molecule made by Merck. It's an oral agent. If again used in the first 72 hours, just like favipiravir, it may clear the virus faster. But whether it will save lives, we don't know. Whether there will be symptom improvement and viral recovery. Same thing may be true with ivermectin, that there may be symptom improvement or viral recovery. But whether it will have any mortality benefit is an unanswered question. So I would say that ivermectin still is a anecdotal drug. We have used it in India. Also in the prophylactic space, we need to generate more data. People have used in the pre-vaccine era, 12 milligram once a week, and that also has been used. But as I said, that it has not generated some high quality evidence to support its routine use. So as I said that, it is neither recommended nor can be said that should not be recommended. So one is ambivalent on that. We are sitting on a fence when it comes to ivermectin, but I have used it in the past. I still occasionally use it if there is a resource situation where a person cannot have favipiravir. It is a little late. The advantage of ivermectin is it can be used at any time in the disease process, mild, moderate, severe, and it is duration independent. But I would still say that does not have the high quality of evidence you need to use it with a lot of robustness. It's economical, it's easily available, does not make it the standard of care. So it's nowhere near standard of care. It's an experimental option which one can explore in a research setting.
Dr. Joshi, is there any downside to ivermectin? As you know, I said colchicine, there's not much downside. Is there downside to ivermectin?
To the best of my knowledge, none.
Okay. All right. I'd like now to open the questions to the floor. Is there any questions from the floor?
So
Yes, Chair. I got one question.
Yeah, Dr. Akhtar.
Yeah, Doctor.
Thank you, Dr. Joshi. It was a very excellent presentation, especially primary healthcare level. I got few queries. Asymptomatic patient at home care base, should we keep 10 days or 14 days? Or symptomatic patient remain 14 days, especially at home care base? The other question is use of remdesivir. I just need, should we start from day 2, day 3, or we wait for the comorbidity and other issue arrive? And
First question.
other freak.
Yeah. So let me take the first question. That if your patient is asymptomatic, 10 days is reasonable, 14 days is desirable, but 10 days is reasonable. For symptomatic patients, 14 days is also fine. And if the symptom resolution is not there or hospitalization is there, it could go up to 21 days. The isolation is mainly the replicative nature of the virus is for the first 10 days. So 10 days is sufficient if you ask me. So that is the first question. The second question is about remdesivir. First 10 days of remdesivir use is good, but it's only for hospitalized patients who desaturate. So remdesivir use is only for moderate to severe disease. It is not for mild disease, and it is not recommended for home care. And the data shows only clinical recovery and length of stay in hospitalization less, but mortality data is not there. So that is where it is. There are some trials of home-based care of remdesivir which are happening. There's also an oral remdesivir which is being made, which is being investigated, but that is all investigation.
Okay, thank you. The last one is oxygen therapy at home. At the moment in Johannesburg and Pretoria in South Africa, hospital beds are fully occupied. There's no ICU bed available. So those situations, home-based care, we are utilizing oxygen and saturation remain 80, 89, 90. And
So
what should we do?
So that's a very relevant point. So remember that even after oxygenation, now the parameters have changed. You can keep your saturation between 88 to 92. You can then in those situations give steroids at home and monitor them aggressively. But that is more of an exception than a rule. But if you don't have any facility and you are forced to do that, the most important thing which improves saturation is prone position. So prone position, oxygen at home and steroids can be given if there is absolutely no access to a healthcare facility. So like, if you said that in South Africa, there is no bed, there is no emergency room, there is no oxygen bed, and if you have to give oxygenation at home, then do prone position, give steroids, monitor the saturation, and keep them at home. That's possible. It's not impossible. When there was a peak of the pandemic, a lot of that happened in Delhi too. But often we don't like to do that. In Mumbai, we have the jumbo facilities, which are like large, compound-like facilities, which are like jumbo hospitals, and we keep the patients there and monitor them under at least a nurse practitioner or supervised medical care, because we feel more confident. In individualized home care, you have to be constantly connected with a healthcare provider, but it is not impossible. So in exceptional circumstances, if one has to do it, but proning definitely helps. Proning has a huge advantage. And I think proning is something, if you are forced to do that, proning clearly makes an impact. So that's something which I want to tell everybody.
Thank you so much. Thank you very much.
Any other questions from the floor?
We have Dr. Angelica. Dr. Angelica, can you unmute yourself?
Thanks. Thanks so much. Thanks for a wonderful presentation. I just would like to echo what Dr. Adkar just said now. In South Africa, we don't have the luxury of admitting patients. So for me, myself, for the past 4 weeks, I have treated successfully more than over 400 patients at home, only admitted 10. And I want to say, and I haven't treated one with ivermectin because I don't know what is going on with ivermectin, and I also don't want to go into the debate with ivermectin. But the most important thing is what Dr. Joshi said. It's the oxygen. It's to make the patient understand. It's to explain to them what the value of the oxygen levels are and the value of the your pulse rate. I also use colchicine, and I use colchicine. We normally see the patients in day 3 or between day 3 and day 5. So I see a lot of chronic patients and elderly patients. So I start on cortisone, which makes a difference to these patients. Sorry. And then it's colchicine, and it's common medicine. It's common sense medicine that you need to use. I let them come into my surgery, so my situation is a bit different. But there's something, Dr. Joshi, that I would like to ask you, something that's very interesting that I've picked up, and I'm not sure why it is. Interesting, I'm starting to see it's only a few patients, but they have bradycardia instead of tachycardia. And I don't know why they start to get a brady, because I've got no history of such a pulse rate problem. So can anyone just tell me what do I do with bradycardia? Thanks.
So, ma'am, that's a very valid clinical observation. We have seen both bradycardias and tachycardias in COVID care. But tachycardia is far more common because of pyrexia. So pyrexia, but if there is pyrexia with bradycardia, it's an ominous sign. And we always transfer or triage the patient very appropriately. Usually there is an autonomic dysfunction which is associated with COVID, and that autonomic dysfunction can lead to brady episodes. We have also seen people in early COVID with temperature of 102 with a pulse rate of 40 and 50. So in those situations, many a times we have lost those patients. So it's important to hospitalize them. That's my only tip I can give, but my evidence is anecdotal. But we know, when I did this literature reading, that it is predominantly linked to autonomic dysfunction. And usually these patients are hypertensive or diabetic. That's the observation which was there. And there is some published literature in that regard also. So it's important to recognize that brady. So both the extremes of pulse are bad signs at home care. And you can occasionally see bradycardia. We have also seen bradycardia with some of the agents like both tachy and brady was seen. Heart rhythm is often affected by chloroquine and hydroxychloroquine. In the first wave in India, a lot of hydroxychloroquine was used. And we did see both hypoglycemia and bradycardia, as well as tachycardia and hyperglycemia when hydroxychloroquine and chloroquine were used in routine care. But nowadays, we don't see that. We've also seen QT prolongations because a lot of them were on doxycycline, azithromycin, hydroxychloroquine, all of them put together with favipiravir. So, when there is polypharmacy, we see some of these challenges. So the idea is to be minimalistic and be very vigilant and do it appropriately. And I also agree with you completely that you can manage patients at home with oxygenation if there is no access. Remember one thing, that 85 to 90 saturation is reasonable in oxygen stewardship. Now there is new data to suggest that it's not that you have to keep it above at 100%. A lot of people, because we had these oxygen audits going on, had this myth that we need to keep the saturations very high. Even if you keep the saturations at 90 to 93, they are reasonable. You don't need 100%. That's because if you give too much of oxygen, it actually harms the lungs. And a lot of oxygen need is dropped down just by proning the patient. So, you can actually, there's a lot of physiology. And that's why I showed a slide when Madam Angelini was talking that, it's important to recognize this fact. So you made some valid points, and probably I'll try to put up on the group the bradycardia with COVID and the likely causes of that.
Thank
So
you
we
so
have
much.
a couple of questions on the chat box, which I will take it. Does India has significant gamma variant outbreak? Singapore is taking more travelers from India. Would our locally deployed Sinovac and Pfizer able to handle gamma? That's first. Second question is, Covaxin seems to be able to handle both gamma and Delta Plus. Do you have any data to share on that?
So as far as the INSOCOG, which is the Indian Consortium for Genomic Studies in India, has not reported gamma from India. What we have reported from India is Delta and Alpha. And you know that in north of India, Punjab, Haryana, and New Delhi and NCR region, we had Alpha in the second wave. We definitely have Delta, and we have a couple of cases of Delta plus. So that is definite, but we don't have as of now a Beta or a Gamma as of now. The likelihood of South American travel to India is less. So that part is very clear cut. Covaxin has very good data in vitro against all the variants. So that is very reassuring. Unlike the Chinese vaccine, which has had challenges. It's been up and down both ways. Sometimes it has got some excellent data, some places it has not got good data. For example, the Middle East and the island Seychelles, that experiment was not very exciting there. So that didn't lead to it. Probably in the killed vaccine category, the immunogenicity may be weaker. So maybe 2 doses may not be sufficient. And you might need a third booster dose. So, Monica was just alluding to that, Dr. Chong was alluding to that we are healthcare workers, probably it's time for us to take our boosters. So for example, in India, we got Covishield in 16th of January. So 6 months have passed now. We have done our neutralizing antibodies. The neutralizing antibodies clearly show a titer which is coming down. So it's time to boost the immunity. But boost with what? We don't have Pfizer. We don't have Moderna still. We have Covaxin with us. Most of us were given Covishield then because Covaxin was not freely available. It was under a research mode. So, these are things, this is according to me an evolving science. And as more and more data will come, and I found it very strange that last year when they launched the Pfizer vaccine, all agencies were together because everybody wanted to vaccinate. So, the EUA of Pfizer coincided with CDC and NIH making announcements. While when they did not want the booster to be given, that science for booster is very robust, particularly with the variants on board. It's important to protect our healthcare workers, but because there's a large unvaccinated population, this was a public policy decision and less of an individual decision. See, in public health, it is most of the time, most of the people. Okay. While in individual health, every life matters. We are clinicians. So for us, every life matters. But the public health specialist will think of most of the time, most of the people for the country. So probably CDC NIH is thinking that, they don't want to start the booster program when there is a large populace already unvaccinated. And they want to ensure that they saturate everybody with the vaccine before they go on to the boosting. But that may not be the best strategy because there are also exposed individuals in the high risk categories, which are people who work in COVID care. And people who work in COVID care need that little boost and protection. So maybe under a research mode or an exceptional mode, they'll probably need to make an official recommendation for booster. And I'm certain that the booster data also is not very sacrosanct. Saurabh, we don't have today, Dr. Chang, that sufficient data to show how long will the vaccine immunity last. So that's an unanswered science question. There's so much of reportage of that, the length of immunity, is it 9 months or to 15 months? That's looking the evidence base. And that's why probably after 6 months, most people know that antibodies decline, but we don't have also an easy test to assess T-cell immunity. We don't have a routine test to assess T-cell immunity. And I'm sure Dr. Monica is immunologist, she will agree with us that, we don't have a routine test for, there are people who are trying to do that to assess T-cell immunity, but we don't have that test available still in routine care.
Pillai
Dr.
here,
Joshi?
Dr.
Yes.
Pillai.
Please, Dr.
In the Indian context, the quarantine, home quarantine or home isolation, how far it is practicable? Because the density of population is so high that a room is shared by maybe 3 or 4 or more people. A person who is in isolation at home may not have the facility of having a toilet to be used by him alone. So these sort of home quarantine, particularly with the Delta variant where transmissibility is high, is it interfering with our sort of control of COVID? Or should we have a different policy where common quarantine areas are available, at least for people who cannot have the comfort and luxury of home isolation? Is there to be a change in policy?
So correct, you are very right. In fact, in Maharashtra, we already have that policy in place that any individual who cannot have an individual bathroom and an individual room has to be moved into a quarantine facility. So we have the CCC, DHC, various facilities. So, for example, in Dharavi slums, in a 1 square feet by 1 square feet, there are 12 people living. They are having beds like bunker beds. So obviously, if one person is positive, that person is straight moved to a jumbo center and is isolated there. So Dr. Pillai, you're absolutely right that in Maharashtra, the policy is very clear that if any person who's not capable of having a single room, single bathroom, connectivity with a digital healthcare system is directly done, and we call it as institutional quarantine. So in Maharashtra, we have a rule that we institutionally quarantine these individuals where they are given food, medications, and they have access to an oxygen bed in a quarantine facility. So many of these are schools which are converted into quarantine centers. These are shelters which are converted into quarantine centers, and they are given an access there so that they can be looked after better. And these are all done free of cost by the government. So, for example, the Bombay Municipal Corporation has 16 such large jumbo facilities where actually proper COVID care is given. But more than 100 plus such quarantine centers where institutional quarantine is done. And in every district, we have 36 districts. We have institutional quarantine. And even across India, there is institutional quarantine facility available for people who cannot have facilities to self quarantine at home with a separate dedicated toilet.
Dr. Joshi, maybe you can tell us a little bit about Delta Plus, because there's some concern in Singapore about that. Although you mentioned previously that it was more like Delta minus. Thank you.
So Delta Plus is AY1. Now you know that the AY1 and AY2 are two variants. AY2 is predominantly based in California. It's a mutation. The reason this Delta Plus became very sinister is because the mutation 417 was there in the beta strain of the South African strain. And because South African strain has been very resistant to vaccines, and vaccines had to be returned back, have been resistant to the monoclonal antibody, there was a concern. So Delta Plus originated from UK, Nepal, and now is seen in India and 8 other countries. In this strain, the data available from UK says that this is more transmissible and transmissibility is similar to that of Delta, number one. Number two, its affinity to the ACE2 receptor is most rigid. So it may affect the lungs much more. And number three, it may be resistant to monoclonal antibodies and it may be resistant and have an immune escape. So those are the possibilities. Now in India, we saw around, from the genomic surveillance, around 40 cases with Delta Plus. These cases had concentrations, more than 50% were from my state. And most of them had mild to moderate symptoms. And most of them were contained and most of them recovered except 2 deaths. And one was a senior citizen, one was a person who was unvaccinated. Most people who got Delta Plus after 1 or 2 doses of vaccines have done reasonably well. So we feel that whatever little clinical phenotype we saw in that little small cohort of Delta Plus, it doesn't appear to be that sinister. So though the theoretical concern is very high and we should be vigilant, probably Delta should be, the reason it's in the Delta category is because of the transmissibility. So transmissibility may be still more, but whether it will be more virulent, whether it will cause more immune escape, we don't know. Whether it will have a different clinical phenotype, current data suggests it's mild to moderate. We have not seen the severe lung cases which are seen in UK. UK will definitely see a spike. UK is already seeing a spike, if you ask me. And with the European football, I don't know whether it will become a spreading or a super spreading event. So it's a huge cause of concern and debate. So though they feel that they are vaccinated, I think they want to build more herd immunity, it's like a flu party which you see at Wembley after they entered semi-finals and they won the semi-finals. It's a very cause of concern for us. And they have a Delta and a Delta Plus both in UK. So I think the data on Delta Plus will come from UK. But from India, the AY1 variant appears to have been contained. But we need to get some more genomic data. And we are doing aggressive genomic surveillance in that area.
Dr. Joshi, in this, I would just like to ask one more question. Like, if this morning you would have read the news in Tirupura, which is one of the states in India, out of 151 samples, there were like more than 60%, almost like 95 people being tested on Delta plus variant. Is that something a cause of concern or a super spreader or something which is like a wave which is spreading? And how dangerous is that, considering the same question coming up?
Yes, we need to be concerned. See, these are all variants of concern. So Delta plus also has been labeled as a variant of concern. But we don't know the outcomes, whether these people recovered, and by the time the genomic result is available, already 2 to 4 weeks have passed. And most of these people have recovered. So, and the districts have been contained. See, India right now is seeing numbers which are coming down. So if you ask me an India update, we are now around 35,000 cases per day. Of these, around 9,000 are from Maharashtra, around 10,000 are from Kerala, and rest of them are from rest of India, which is mainly Tamil Nadu, Andhra, and all northeastern states. All the northeastern states are seeing this spurge and very high test positivity rates, about 10% on those districts. So these are all districts of concern. So even in India, we have 700 plus districts. 90 districts are districts of concern. In our state, we have 14 districts of concern, mainly 6 to 8 of them much more. So in each of the districts of contain, we need to contain aggressively. We need aggressive testing, treating, tracking strategies. We need to do the perimeter limiting, and we need to do the micro containment. So that is the only way we can do it. I think, Saurabh, there is a concern, but there is no need to panic. That is all I would say. There is no need to panic, and we will have to restrict mobility from some of these zones. So probably otherwise there will be spreading. And once there is spreading and there is a community spread, then it's very difficult to contain. So the worry our Singaporean colleagues have is very logical, because one Delta entry saw a spurge of 1,000 cases there.
Yes.
One Delta plus entry will see another 500 cases, but it may not be 1,000. That's probably but as I said, I could be wrong. Okay, this is an indirect conclusion I'm making based on the available evidence today. So it appears to the R0 of the Delta plus may not be 7. It's not 3.5. So it's probably between 3.5 and 7. So it's probably at 5.5 or 6.
Our experts here have ranked it at about 5 to 8, the R0. One more thing I never really got to ask anyone, but can you shed light on why the Delta is attacking children? Because from what I understand, ACE receptors in children are much less than in adults.
So see, this pediatric wave, I think, is overhyped. And I would like to take an input from Dr. Monica also. But I think they have overhyped this pediatric wave. I think children have a very good thymus and they are able to clear viruses better. So I think they can clear Delta plus also better. Children are spreaders, super spreaders. We don't test children very frequently. Yes. We have tested children indirectly through antibodies. So I think the Delta may not be having such a predilection. Only thing is, children will be the only cohort in the world which will be unvaccinated. So because it's an unvaccinated cohort, it will be a vulnerable cohort. But I don't know whether children are unexposed. So that's something which we don't know, because a lot of children at their houses got exposed when their family members had COVID, but they were never tested. But when the antibody testing was done, and that is what the AIM study showed, when the antibody testing was done, or even in Mumbai city, when we did the survey, sero survey, we found children were as affected as adults in that family. So if the adults of the family were exposed, they were also exposed. But we never tested the kids, because kids testing is not easy. In that population, to test children is not easy. So I would not be, there would be a pediatric wave. I'm not saying there may not be a pediatric wave. But I think that the children exposure has been less than adults, but it's a vulnerable group. So younger population, which is less exposed, will be more vulnerable. But I think we should not put too much to it. But Monica, any US data on children? Because I think they have a little better quality data than rest of the world. But again, we are not very sure whether, because whatever experience in pediatric space has been there, I think children have done very well.
I agree with you. Children have done very well. I don't have the most updated information, but even if you just look at your ICU or your children's hospital admissions, you're not seeing very many children. We had the reports of the MISC that was earlier, but children are not getting as sick. You see family households where there's household spread, the children remain asymptomatic and one of the two parents is sick. But no, I don't think that the children's is a big issue unless we're talking about school openings and public health policy regarding openings of schools, because then the children who are asymptomatic spreaders are going to infect the teachers and the support staff was more of an issue. I agree with you, Dr. Joshi.
Thank you very much. Any other questions from the floor?
Angelique, yeah, can I just,
Yes.
my last 5 seconds. I want to echo what Monica and Dr. Joshi is saying, but that's exactly my same experience. And I'm even at the stage where I say to the parents, don't, if you are sick, it's difficult to get the children to quarantine from the parents. I said, just let them run around. You will not even know that they are sick. And we haven't seen seriously ill children. Maybe a little bit of snuffles for a day or two, they get out of it. You don't need to treat them. The other thing that I have seen with this Delta variant is that in a household, we also have the same problems in South Africa with people living in a room together. There's not really any quarantine, and we do not have all these nice things that India have. So normally anything between 1 to 28 days, the second partner or whoever is in the house would be affected. So what I'm trying to say is we are trying to say to the patients, so maybe after your 10 days of isolation, which we know is not really going to happen, maybe the next one will then be contagious or get starting with symptoms. So you can, up till 28 days, we have seen. I'm not sure what the Dr. Joshi has got, or Dr. Monica has got another thing on that. And then, yeah, that was the big thing that I wanted to say. Thanks.
Thank you, Angelique. Saurabh, how are we for time?
We're just 10 minutes, I would say. So we can, I think we can take an update from countries which are like in a problem right now, rather than having a complete update. I see a lot. Anybody from Indonesia over here, or anybody from? Yep. Okay,
maybe,
so Mr.
Ravi, Mr. Ravi, Dr. Ravi from Malaysia.
Yeah. Okay. Well, Malaysia is in a very bad shape. Our cases have increased now. As of yesterday, we have seen about 9,000 cases. And the only good thing in Malaysia today is the stepping up of the vaccination. I think we have now, we are vaccinating approximately 300,000 to 400,000 per day. I think as of yesterday, it was 375,000 people were vaccinated. But in terms of the spread, it's pretty bad. We are at 8,000 odd cases. We are still in a total lockdown. And, as you know, this will affect the businesses or the economic side of it. Questions from the public: if there's a lockdown and the cases are not going down, why do you lock down? Where have we gone wrong? That is the question here. That is what people are asking now. Yeah. But while we are on this, Dr. Joshi, just one simple question, because ivermectin, again, I'm getting several calls from people asking about ivermectin. Can it be given? Will it cause any other effects if it is given? What is your opinion on this, Dr. Joshi?
The question continues.
I'm very clear about it. If you don't have anything else to offer, then give 12 milligram twice a day for 5 days. You are good. I'm very simple about this. But if there are other things available, ability to monitor, ability to be clinically appropriate, then it's a research tool and you can publish that data on it. So I encourage that, write a protocol, get an IRB approval and get them on ivermectin on board. That's the best way to do it.
So you say 20 milligrams BD, is
12
it?
milligram twice a day for 5
12 milligrams.
Or use a milligram per kg body weight dose.
Okay, thank you.
I have treated many, in the last 1 year, I have treated most of my patients without ivermectin successfully.
Yeah.
I have not seen any challenges. The protocol which I just told you, it doesn't have ivermectin on it. I don't have access. All of my patients, none of my patients can afford antibodies. Few of them can, and they do extremely well. Most patients with mild COVID, whether you treat or you don't treat, will do very well. Okay. It's only that you need to filter out those 20% who are likely to deteriorate. And that is the art. So the only art you need to know in home isolation is to pick up the people who are likely to deteriorate. And that's the only thing. So ivermectin, don't get hyper about it. If you feel that you want to research on it, do it in the right dose, milligram per kg, write a protocol and do it. It will show that in mild disease, virtually everything works.
Can I have
because
Mary?
sorry, just to end that the conversation, because what's happening is there's so much of hype on the social media about ivermectin. People are tending to get it on their own and treat themselves with ivermectin. That's what I was trying to say here. Thank you.
To add on to what Dr. Joshi has said regarding Indian scenario, Dr. Pillai, our second wave still is flattening. It is not over, because per day we have 42 to 43,000 cases detected, and the positivity rate variable, but up to 12% goes on. And even Kappa variant, at least in 4 or 5 patients, it has been found that they have it, but it is significant still is not known. Our immunization, definitely those who had got both the doses, even if they contract the disease, it is very mild, and mortality among them is almost not there. So that's a great relief. But our vaccination program, 8 million was the target per day, but we have achieved almost 4 million per day. And so it is going to take more time, and acceleration of immunization is the only way out of the situation. But our problems with bed and oxygen and medicine and other things are fastly sort of addressed, and those problems do not at least exist, maybe because the number of patients are also less. And the government is also getting prepared even for a third wave in terms of adding on facilities. And so things are under control, but it needs more time to get it solved. And now the Sputnik vaccine also is available apart from Covishield and Covaxin. And the studies done on Covaxin are very much encouraging. Indian vaccine developed in Hyderabad Biotech Lab. The results are very encouraging and at par with any other vaccine developed in other countries. And definitely we are proud that we could develop a vaccine, and that too maintaining the highest of standards. And availability, we do have problems, but it is being sorted out. And other vaccines are also going to be introduced in our country, and whether a booster dose, at least for health workers, to be given is being debated. Maybe, as Dr. Joshi has already said, it is almost 6 months after the health workers have been vaccinated, and maybe on the basis of the antibody studies which is being undertaken by ICMR, a decision on that also may be taken. Thank you.
Thank you, Dr. Pillai. Can we hear from Marie in Japan because of the Olympics? And is Marie around?
Yes, just a moment, please. Oh, yes. Yes, we have about 2,000 tested positive for PCR, and this is around 20. And also, intubated patient is only 65. But government decided to go quarantine first time. And I called it pre-Olympic quarantine. So we will see, and the next 2 weeks we're going to have Olympics. But all the games are kind of without audience. So we will see what will happen next. Thank you.
Thank you, Marie. Thank you. Thank you. I hope the Olympics go well.
Thank you. Thank you very much.
Yeah, they have announced the emergency for Tokyo, I would say, 2 weeks just before the Olympics.
That's right. Yeah. And can we hear from, is anybody from Pakistan, or I can hear from Dr. Russell as to what's happening in Melbourne or Sydney?
Thank you. Melbourne is good, as you know, but we have run into problems in New South Wales, Sydney per se. and it seems to be getting exponentially going higher, while the rest of the country is pretty much no. Melbourne, I think you're Dr. Chong, you'll be happy to know today is, I think, the 10th day without any cases. But we have this problem, and New South Wales, as you know, did not have too much of lockdown, and they delayed it. And unfortunately, our vaccination, that's probably the lowest in the country too. New South Wales, largest state and lowest. So we've had this problem, and it has moved to the southeast, which is ethnic, highly ethnic. 50% will be born outside, and so they're having difficulties trying to control that, and brought in police and so forth. So that's the situation in New South Wales. The rest of the country seems to be fairly, so it's all sealed now.
Okay, I would say now we are at the end of the session. I would like to take this opportunity to close this session. We are overlapping now. Good part of bringing good speakers are that the session goes on the other sessions, and they I get a stinker from them. So thank you so much for Dr. Joshi for presenting the wonderful data.
Thank you.
It was an excellent presentation, and thank you everyone for joining in for the 66th webinar. And I would like to close this meeting with a comment from Dr. Joshi saying that as a clinical, we are focused for the individual health, and as a public health, people are focused on mostly on everyone's health. So that's a very good statement, and that totally narrates on what Dr. K.K. Agarwal used to do, treat patient on an individual level. And with this note, I would like to close the 66th session on International Weekly Meeting in association with CMAAO. We have a roundtable conference going on after this session, which will be headed by Dr. Kalra, and we have all the roundtable experts after this. I would like to close this meeting, and thank you so much for joining in. See you next week, same time, same week, same day. Thank you.
Thank you.
Thank you very much.
Thank you all very much.
Thank you
Bless
all.
you all.